So we are starting, and participants are already here, hopefully. And everybody could hear me. I'm Hanna Dovbach from Eurasian Harm Reduction Association, and I will be your host here during this hour and a half. And what we will do during this webinar, which called Unpacking GC8 TB Guidance from a Community Lens. We all understand that the Global Fund Grant Cycle 8 come in a critical moment for global public health and TB response. Funding constraints, competing global crisis, and shrinking civic space are placing increasing pressure on national TB programs, particularly those targeting key and vulnerable populations. And here in this webinar, organized by 6 regional learning hubs of the Global Fund, led by ICA Regional Learning Hub, hosted by Eurasian Harm Reduction Association, we will unpack what is there in the guidance, how could we use it, what tools we do have, and we will understand what are the key opportunities of Grant Cycle 8 in reducing inequality, in ensuring human rights and gender equality in TB services, and strengthening capacity of civil society actors, community affected by tuberculosis to engage in Grant Cycle 8 funding, request development, including prioritization of key interventions. We have very packed agenda. That's why I want all the participants to ensure that you are asking all the questions in the question and answer section. You could see under the in the bottom line of the screen. We do have translation, and it's very convenient and very important for you to hear in the language which you know more best. And please go to the globe sign to choose the translation sign, and you could get French, Russian, Portuguese, Spanish, and what else? You could find the languages.
We will have Arab translation, but on the Korean channel.
Yes, if you need Arab translation, please use the Korean, because Zoom is not supporting on all our languages. I'm sorry for this. So you could see, if you need Arab translation, you need to go to Korean sign. Sorry for this. So choose your channel. All the meeting will be recorded in these languages. So if your colleagues or you need to go back to the presentations or what has happened, you will have opportunity to get it. So we will start from the overview of Grant Cycle 8 modular framework and prioritization guidance for TB. And we are giving floor to a marvelous colleague, Jamie Tonsing, who is disease advisor on TB and technical advice and partnership department in Global Fund. And we are actually coming to the presentation. I hope everybody could see it now in the proper mode. Yes. Now, Jamie, floor is yours.
Thank you very much, Ghana, for the introduction, and lovely to be with all of you, dear colleagues from all over the world. So I'm very glad to be presenting to you the GC8 TB guidance that is also now available on our website since last week Monday. And then you will find much more details here. This is just to give you a brief glimpse and summary of what we have for guidance for GC8. Next, please. So this slides will be shared with you. So I put a link there on where you can find all the documents. And see on this particular page, I point your attention to the modular framework link that is there on the first line of that content. That is what we'll also quickly touch now. And then you'll see all the other guidance on HIV, TB, malaria, and RSSH. You'll find the English, Spanish, and French translated guidance for all documents posted on our website. Next. So let's start with TB modular framework. I think for many of you already probably know, the way all the interventions funding request is done, it's around TB modules or interventions, so we can track what activities are under each module. We can see also it is linked to the how we budget and how we summarize the budget. So it's important that we maintain this framework of modules and interventions. So the ones in the dark blue, they are the modules, and we have 6 modules for TB on diagnosis, treatment, care, DRTB diagnosis, treatment and care, TB, HIV, DRTB and TB prevention, key and vulnerable population, and collaboration with other sectors and providers. And the ones in light blue are what we call interventions. So, for example, the first module, TB diagnosis, treatment and care, has 2 interventions: TB screening, diagnosis, TB treatment, care and support. And likewise, you will see all the related interventions for each of the module. And when you build your proposals, you will be writing what activities you propose, and they are to be linked. The activities that you propose are to be linked with these interventions and modules. So in the other thing to note is, compared to GC7, we have now fewer modules and interventions. So it was in GC7, we had 7 modules. Now we have 6. And the reason for that is the equity, human rights, that module is gone to RSSH module from the TB module. So, and all related interventions. Next, please. Okay, so I'm sure you've heard a lot about the grand cycle 8 strategic shifts. And so this is really the big shift that we're making as we compare to the other years. And I don't expect you to read through this, only please look at the ones on the right-hand side of the slide. You will find that there are 6 strategic shifts. The 1 and 2 are more at the global level, really for the global fund that we've set transition pathways. Some grants are ending in GC8, some in GC9. Money is moving from, more money is being given to lowest income, high burden countries. So those are what has already been done through the allocation letter and through the transition cycle communicated to countries. In the guidance, in the funding request, we want to see more focus on 3, 4, 5 years. So really programmatic prioritization. I think because we have less money compared to other years, it's become even more important why we should prioritize. We are also looking at integration as a way to be more efficient, as a way to be more sustainable in the future. And then the third angle is really about reaching out to community systems and financing for them, making sure these are available. You may have the best tools, best interventions, but if they don't reach the people who need it the most, then it doesn't make any sense. So really, these 3 are the priorities for funding request development as we move forward. Next. So TB program essentials, this was introduced in grant cycle 7, and they're continued in this cycle too. You will see that for each tech area, there are a total of 15 program essentials covering things like screening and diagnosis, the use of WHO recommended initial tests, and then on prevention, treatment, care, TB, HIV, and cross-cutting area. I want to point out that there are 2 new program essentials in GC8. One is really around on the cross-cutting on the right-hand side, the first bullet point, around innovations. We're really encouraging countries to adopt innovations, particularly those that can help save costs, like the near point of care test for TB and sputum pooling sample, which is also now WHO recommended. And then the next issue is on around next program essential is on integration, integrating TB in primary healthcare and also within the broader health system. What I mean by this is, how can we make TB services to be part of the basic health package delivered at PHC level? And the second part is, there are system issues that that TB could contribute to or benefit from, like supply chain, data systems, human resources for health, community health workers. So these are resources that go beyond TB. So how can we make sure that we are not building siloed systems for TB, but depending on and co-leaning on what's already available and strengthening and making that more effective. Next, please. Here is an example from the 17th slide prioritization guidance on what we're calling as priority intervention, what we're calling as lower priority. So I spoke about one prioritization as a big shift for GC8. So it is for the first time that in our guidance, we are spelling out what is priority and what is of lower priority. We cannot say, we're saying using purposely lower because everything is country context dependent. So, but in general, this is what we want countries to consider as in the country dialogue when you're talking and developing funding requests. So some examples on screening and diagnosis. Well, because we want to use better, more sensitive tools, so we're promoting chest X-ray for screening instead of symptom screening, and then where possible to use the AI software, and also molecular rapid diagnostic test, near point of care test, LF-NAM, and then sputum sample spooling. On the other hand, we're saying that sputum microscopy should no longer be used for diagnosis. It is true that globally we are just the coverage of molecular tests is still only around 50%. So some countries are still using sputum microscopy. Unlikely global fund will pay for sputum microscopy. We think the only role for sputum microscopy is for treatment monitoring rather than diagnosis. And we also note that sometimes we do active case finding campaigns, and these are continued even if they don't, if we're not able to get the expected yield, if they're not performing well, for some reason continues. So we are urging that those ones that we monitor strictly and we stop those that are not giving you the results you expect. On treatment, focus is very much on the shorter regimens, especially the 4-month regimen for severe, non-severe childhood TB. And on the other hand, there is also a 4-month regimen that came for adults. We are deprioritizing that rifapentine-based regimen for people about 12 years. We're saying that's not a priority, mainly because it costs 4 times than the standard 6-month DSTB treatment, and it does not necessarily give you better outcomes, and it has a high pill burden. So for that reason, we're saying that's lower priority. And on DRTB2, we're saying let's use the 6-month regimen. There are 2 of them now. And only if the people are not eligible for that, then we go to the longer regimen. On prevention, we are prioritizing, for example, between tests. We're saying let's prioritize antigen-based skin tests over interferon gamma release assay because it is because antigen-based skin tests are more easier to use because they don't need a lab structure, and also it costs much lesser. So on TPT, I think we are saying if you are in a resource constrained setting, we are not expecting TPT to cover every eligible groups that may be required. So if you have to prioritize and focus on children below 5 years for household contacts and PLHIV, because these 2 groups are the ones, if they have TB, if they break down into TB, they can have severe forms of TB. And so the impact here is much more. And the second reason is they don't need TB infection testing. They can be straight away put on treatment. So that's why we're saying let's prioritize this. If there are no issues, but this could be context dependent. For example, if you're working in a very low burden setting where you are really trying to eliminate TB at that stage of it, then TPT is important for a much wider group than this. So it has to be context dependent. Strategic information, what is low priority now this time? We are very unlikely that global fund investment will be used in those big costly TB prevalence surveys that in the past we have been funding. So that's low priority now. And then on cross-cutting, I want to point out that in GC8, there are 2 groups of people that we have included under key vulnerable population group: people in fragile and conflict-affected settings, and people affected by extreme weather events and climate. So that's one group. And the other thing is on cross-cutting to note is that we are continuing to support very much encouraging integrated and evidence-based programs to address access barriers, because we do know, especially for KVP key vulnerable population, they continue to face barriers that needs to be addressed. So that's a high priority intervention. Next, please. Okay, so I pull out from the GC8 TB prioritization guidance 2 slides that are related to one is on TB community-based care that I present here. This is as it is on the website. This falls under the intervention community-based TB TB care. And as I said, there are activities that are prioritized, shown in the dark black, and in gray are the activities of lower priority. So things like continuing to meaningfully engage TB communities in national and subnational TB response, really supporting community-based and community-led service delivery, organizational assessments and capacity building of organizations, sustaining community-led monitoring. These continue to be areas that are prioritized. On the other hand, what's of lower priority are things like support for learning and exchange of best practices, use of community-led research, unless there is clear link to programmatic decision making. So these are lower priority. Next, please.
Jamie, 1 minute.
Yeah.
Yes, please. Yes, continue, but just 1 minute left.
All right. Yeah. Next, please. Okay. I thought you wanted to ask a question. Next, please. Yeah. So the previous one. So the other one is on cross-cutting. And so similarly, what are the TB barriers? We prioritize them into areas for high priority for global fund investment and low priority for global fund investment. And you can look at what these are details in later on. So with that, I'll hand it over back to you, Anna. Yeah.
Wow, perfect timing. Thank you very much, Jamie. And we do have at least 2 questions or 2 hands to ask the questions. So, dear colleagues, just be very quickly, and I'm reminding you that you have the question and answers section. You could have more questions asked, and I'm giving floor to Leko Mwawi to ask the question. And we could take off the presentation if it's possible. Leka? You could speak now, I guess. Could you? Hopefully it will work. You need to unmute, Leka, and then take a floor if you're here. No, I could not hear from Leka. It's sorry. Then let us switch to Natalia Sergeyeva. If you hear, if you have any question, please ask. Natalia?
Sorry, yeah, probably by mistake. Thank you very much.
Oh, sorry. And then I have Stephen John. Please, you could ask the question.
Yeah. Good morning, afternoon, evening, everyone. My question is about this particular group, people affected by extreme weather. So I wanted to find out if populations that we have been targeting in the past, for instance, the nomadic pastoralists and other migrant populations, are listed under this particular new group. So this is my question. Over.
Thank you. Please, Jamie, do you have any answer on this?
Yeah, sure. I mean, so KVP, key vulnerable population, there's a whole list of table of people that belong to that group. I did not mention all of them. I only added the 2 groups that were included in Grand Cycle 8. So people like minors, people like who are in prisons, people who are also the malnutrition, smokers, people who abuse drugs. So the standard, those kind of people are already there. I'm just mentioning in the context that because extreme extreme weather events are becoming more and more common, and we are seeing that impacting people getting displaced because of floods, not able to continue their treatment, because countries losing the whole supplies of warehouses because of those. So for those reasons, we put it in here that you can put in activities to weather-proof your TB response, making the digital tools, for example, to make sure people are, where people move when they go and continue treatment. So yeah, that's it. That is what it is. I'm happy to post the whole list of KVP groups that I didn't mention on the chat later on. Yeah.
Thank you very much, Jamie, for this global overview of the modular framework and prioritization in such a short time. And if anyone have any question, please use the Q&A section to ask questions, and Jamie and other Global Fund colleagues could comment and answer with the links and everything needed for you to prepare the proposal. And we are switching, then we are stepping to the next step of our agenda and our discussion, and I'm inviting now the representative program officer Atul Stenge from Global Coalition of TB Advocates to present the key shifts and non-negotiables from the grant for grant cycle 8 and opportunities impact on community. Atul, could I hear you, and could you show the slides if you... No?
And it seems he's not with us yet. So let's
Switch to the community representatives.
Yeah,
So absolutely.
if he will join later, we will give him.
I will check if Atul will be here. Maybe he will close the meeting then. Okay, then our idea was to share what was the challenges for grant cycle 7 for communities, for civil society, what are the best practices and what we could use for grant cycle 8 from the community perspective from different countries and regions. And in this panel, we will have 3 speakers from Nepal, from Moldova, and from Kenya, all the globe here. And I hope that you will get questions to our absolutely amazing speakers to ask how you have done this, what was your lessons learned. So we are first traveling to Nepal to Sarah Gopali, Executive Director of Japan-Nepal Health and Tuberculosis Research Association. Please, Sarah. Sharan. Sorry, I'm good. I'm bad with this. And please.
Can you see my slide? Hello?
Yes, now we will find the slides for you.
Yeah,
I see. I don't see your slides, no.
Can you open, Sharon, can you open your slide yourself from your, as we tried?
Yeah. Share, right?
Yeah, full screen share.
Yes.
Yeah, we can see the slides. Thank you.
Very good. Yeah.
Okay, thank you. Good morning, good afternoon, good evening, everyone. Thank you for this opportunity. I would like to share our experiences in Grant Cycle 7 from the Global Fund Grant about the role of community in active TB case finding, targeting key and vulnerable population in Nepal, where we are in the Southeast Asia region. According to our prevalence survey, that demonstrated large pool of undetected TB cases are still exist in the community. More than 70% of the confirmed TB cases do not have any cough for more than 2 weeks or other symptoms as used for TB screening. Screening for TB using cough of more than 2 weeks would have only captured around 21% of the TB cases, and the prevalence survey has indicated that sensitivity of symptomatic screening is low, so chest X-ray should be used to avoid any advanced TB cases without TB symptom in the community. Based on this, during the Grand Cycle 7, in this diagnosis, treatment, and care model, we have received some grant for the Nepal. So basically for the active case finding, targeting the key and vulnerable population, where mapping of key and vulnerable population using simple assessment tool was designed locally, because as per the prevalence survey in the 99 cluster, 20% of the cluster contributed majority of the cases find from the prevalence survey. It means that there are some hard to reach and high risk areas where we need to do proper mapping with the meaningful community participation, because they know where are the cases, where are the vulnerable population are residing in the community. With the support of the community and local government, we have developed planning, and based on their recommendation, the team do chest X-ray screening with the CAD AI in the implemented districts. So when we do this community-based TB screening targeting vulnerable and hard-to-reach population from July 25 to February 2026, we could able to screen 23,565 people in the community. Among them, around 6% were eligible for sputum collection. This means it's more than 15% decrease of unnecessary collection of the sputum and testing in the expensive molecular test. So among the 6%, we were able to diagnose 334 cases, which is around, among the presumptive, around 8% who are the positive and other are clinically diagnosed. And among diagnosis cases, 98% were able to enroll into treatment. It means that having community-based active case finding with a dedicated team can reduce initial loss to follow-up. And the yield rate from this intervention is 2%, which is much encouraging in the community to find the asymptomatic TB patients. TB patients, yeah. And among the participants, 53% were female, where this kind of intervention able to increase the access for the females who are working in very hard to reach area and they have a limited access to the health facilities. And among total diagnosis cases, 69% were clinically diagnosed and 31% were bacteriologically confirmed. The key message here is if the country, if the global fund, if the donors want to expand the active case finding in the community, we need dedicated trained medical team, where we call it clinical panel, to support for clinically diagnosis cases, because we found around 70% cases are clinically diagnosed with dedicated team. And trend of TB screening among prison inmates as a key population. JANTRA as a sub-recipient for the Global Fund, we have practice of screening in the prison every year, and we found that the result is quite encouraging. The number of cases we identify, we diagnose from the prison is, which is 2 to 3 times higher than the general population. So this is the key program we need to continue in the Grand Cycle 8 also, targeting this key population. This is a clear message from the data. The lesson learned from our intervention is that more than half of the presumptive TB cases have no any sign and symptom. It means we are talking about eliminating, ending the TB, and if we don't diagnose the asymptomatic TB, people are transmitting disease in the community very silently. The selection of target groups, key vulnerable population with the support of community leaders, health volunteers and TB survivors is key to maintain high yield rate. If we can really go for the poor service access, service needed population, then we can maintain the yield rate as per the target given by the National Strategic Document or the Global Fund proposal frames. High acceptability from the local community, including high participation from women and senior citizens. women and senior citizens always left behind in the hard to reach population because we have a very hard terrain, geographical terrains where they have a limited access. So this kind of activities can improve their access. About 40% of the diagnosed cases from active case finding need to link for the community-based dots. They cannot come to the health facility. It takes like 2 to 3 hours by foot. So in the Grand Cycle 8 also, what we have to design is the importance of community-based dots or family-based dots based on the national strategic application. Meaningful participation from the local government. From the beginning, what we try to do is for importance of the co-financing. When we invite local government in our program, they supported us like transportation cost for the participant to come in the campsite and use of social media for advocating and awareing in the community for the camp day. This was very helpful. And in conclusion, what I would like to say is active case finding with chest X-ray in community and congregated setting is very effective, especially for asymptomatic TB. That is for both bacteriologically confirmed and bacteriologically negative also. Improving the testing capacity is the critical because if we expand the active case finding, we need more sensitive tool like a MWRD, which is the capacity should be increased. The existing capacity is not sufficient for this kind of activities when we go in the community. Health education, health promotion, which include IEC materials and information about DOT centers for individuals. Many people don't know about where is the DOTs available, and that will help us to reduce initial loss to follow-up and perception towards the screening camp of the community people. And way forward for the Grand Cycle 8, I would like to suggest that the implementation of pool sampling or tongue swab and point of care is critical for decreasing cost, turnaround time, and replacing microscopy tests. The experience what we gain from this Grand Cycle 7 is among total participants who are eligible for sputum test from the X-ray screening, 5 to 7% couldn't discharge the quality sputum in the campsite. So morning sample is important. For this, I think community can be play good role for collecting sputum, morning quality sputum sample and link to the diagnostic facility. And the point of care, yes, as I said, we have a limited MWRD site and we don't want to entertain this in the microscopy test. Using sensitive tool, we need sensitive diagnostic tool also for the confirmation test. Expanding active case finding campsite in the large population requires a dedicated team. It is not single person can do this. We need dedicated team and resources to address the impact of TB epidemiology. If we really want to decrease the incidence of the TB, as planned like a 10% every year, we need dedicated team to robust system to work in the community. Going in the patchy way will not decrease the impact of the TB epidemiology in the community. And recently we have completed community mapping and it shows that stigma and discrimination is one of the primary barrier for the community people for diagnosis, treatment, and care also. For this, TB advocacy at all levels from central to community is critical for effective implementation of the TB control activities. Thank you so much. That's all from my side.
Thank you very, very much for such a lot of lessons learned and examples. We do have at least 3 questions to you in the session of question and answer. And we are now coming to the next 2 country examples. And if some of the questions could not be answered in written in the section, we will be back to them. And now I'm inviting you to the beautiful country of Moldova. And Sharan, could you switch off your slides, please? Stop sharing somewhere. Yeah. Thank you. And I'm giving floor to Society of Moldova Free of Tuberculosis representative organization SMIT, and Oxana Rucsineanu will present their experience in Moldova.
Thank you, Gana. Do you see my slides?
Kind of, yes, because that's just introductory slide and I couldn't recognize it if it's yours.
That's fine.
Please.
That's fine. Yeah.
Good.
Thank you so much, Ghana, and thank you, Sharan, for sharing the experience from a different country. And as well as from our perspective, we would like to share what we have done and what we have achieved during this 2 years of Grant Cycle 7 implementation, and would encourage other communities to follow some of our practices, so that we encourage that we do have resources for developing capacity and coordination of civil society and community, because this is a critical point. So I will address the gap, let's say, of limited institutional capacity and coordination and partnership among TB society and communities, NTP, CCM, because we do acknowledge that we are not very often speaking about the institutional capacity of the organization, which are providers of TB services at country level, and we need to address this gap to ensure that we engage meaningfully civil society in policy making and policy implementation and in any other processes which relate to TB response in the country. As per WHO guidance, we do understand that to create a favorable environment for community engagement, we do need to address the critical elements in place for this, and we need to see what is the situation in the country when we are speaking about the legal and policy framework. Do we have the supportive legal and policy framework within the country which will enable civil society and people affected by TB to contribute to the TB response? Not only saying that we have the legislation, but do you have practical tools which are in place and which really ensure the engagement of the civil society organization? Why I'm using the civil society organization? Because within the country, this is the legal framework where the communities gather together, and they are called non-governmental organization, and they are acting to engage meaningfully. The other key element would be the coordination and collaboration platform. Do we have civil society and community engaged in those either formal or non-formal platforms where partners, including communities and civil society, can discuss and have a meaningful dialogue, can engage and can share information, align community action within the health system to ensure that the community and civil society are complementing the national TB response, and they are not doing their job something apart, but working in partnership with health system and helping there where the formal structures cannot reach the population. And we are speaking about the integrating the TB as a structural component in the national TB care model with proper financing, proper mechanism of tools of engagement and so on. And of course, we're speaking about sustainable financing. We cannot engage people just saying that we engage communities and civil society, and we do not have a budget line in the project proposal where we show what is the allocation dedicated to do all this practical work at the ground level by civil society and communities. So in Moldova, what we did is actually within the development of the GS7, we ensured that we have resources, and this is where it comes from. We ensure that we have strict budget lines which are dedicated to community engagement in service delivery. We had particular resources dedicated for active case finding and for adherence support. We had particular budget dedicated to advocacy and CLM activities. From the other side, we saw that this is not enough, because to engage people in decision making and policy making in implementation discussion, we need to have a genuine budget line to ensure that we are focusing on the capacity and leadership of communities, because we need to ensure, and therefore we developed a proposal which were focused on two streamlines which were dedicated to strengthen TB platform. This is a non-formal gathering of TB and community representative, which includes over than 14 organizations at that moment in the country, as a mechanism for coordination of these service providers and advocacy organization. And the other point would be we had a separate budget line to strengthen the community engagement and to be research and innovation. Another new aspect which we touched in the country to ensure that the communities have a proper platform to discuss the innovation, the research, and the impact on the community. In this way, paving the way for a good and based advocacy to ensure again new things reach the populations. What was the plans and what were the outputs is to organize very simply monthly meetings to discuss progress and implementation, and at the same time not to forget about the challenges, because we do what is planned is one, but when we are starting working, you have challenges and you need to build a unified voice of the communities which are working as a providers to come to the minister, to come to the NTP and to say that these things work good and this needs to be improved. We ensure to have thematic workshop to increase capacity of the member organization, workshop to share and discuss recent researches for major impact on the community, and to develop, which is absolutely critical, community positions on the different emerging issues within the implementation of the grant, as well as of the activities which are part of the national TB response in the country. The outcomes was to engage, the expected outcomes was to engage the policy discussions, implementation, decision makers, making, and have an improved coordination and unified voice, because this is, I think, which is lacking. We know that the communities are very different, organizations have different their own organizational priorities and so on, but when we are coming to the government, we need to have a unified voice. Otherwise, we will be lacking a lot of chances. The resource, what the resources contributed and what are the results is actually that we managed to do a lot of good things. Speaking about strengthening institutional capacity in developing leadership and advocacy, we managed to align with governmental standards, which are not openly speaking. Is Global Fund actually looking at the governmental standards within the countries? Because if we are not looking and we are not aligning to what are the countries do, what are the country doing, what are the costs of the services, we are faced to miss the opportunities. We need to see what is in the place. We need to respect the standards of the country. Therefore, every organization which pretends to be contracted from the national funds have applied to obtain this utility certificate. This is like a necessary obligation for the organization to work. Within the support provided within the grant, we have consistent and timely engaged in different relevant processes, especially just today we have the country has adopted the new national TB response for the next 5 years, which has happened with a lot of support and feedback from the communities and civil society. Civil society and communities participated in training opportunities. And this is not about only participating at the opportunities which has been supported by Global Fund. It's about sharing the information about global opportunities, which are so many with this online possibility to join, only to structure the time and participate actively. As well, we did a lot of communication through a fiber group, a community group which gathered over up to 40 members of the civil society with a lot of updates at the national level and the global level. As well, as through the discussion and work, we developed as a platform. Many position papers have been submitted to the Ministry of Health. We offered feedback on prioritization of territories and intervention provided within the national program. Number of community of civil society representatives have increased at the level of CCM. We had only 3, now we have 4 representatives. And even the vice chair of the CCM now is represented by a drug TB survivor. And already mentioned about the active engagement within the development of the new national strategic plan for TB. Speaking about community engagement and implementation, we need to speak about financing, because this is a concrete result. The allocations, domestic allocations for active case finding have increased in the last years. The other point would be that Global Fund grant, a national medical insurance company, but the national contracting agency, is using the same costs, which is actually a good indicator that the activities will sustain in the future, even when the Global Fund will leave the country. And now, within the next grant cycle, Moldova is actually in their last chance to improve things and to strengthen those things which need to be strengthened, because we will not have other opportunities. What is again important is to mention that we, as a member organization of the National TB Platform, have insisted that every organization which is working should apply for domestic funding, and it was not like optional. If you want to be contracted from the Global Fund, you need to at least try and to submit the package of documents when the national funding is calling for the applications to do service delivery, and we're speaking about active case funding. Therefore, Moldovan civil society have taken a significant step forward in aligning with governmental standards to build partnership among stakeholders and to build a foundation for a solid role as a key partner in community health and development initiatives. To conclude, what we can do and what we can still apply is, of course, to see comprehensively at every piece of the puzzle, not separately, to ensure that we have resources to support institutional capacity as well on leadership, because otherwise we will not have meaningful engagement in policy discussion and policy implementation. We need to ensure in place funds to continue community engagement and service delivery. And not to forget about the proportionate of the resources. Allocate resources taking into consideration what is the impact, the overall impact on the national TB response. Align resource allocations. We need to think if there are other donors of the country, and we've never discussed it. We are insisting to discuss every opportunities which comes for TB or HIV at the level of CCM, not just the Global Fund application. And this still a lot of things to do about aligning these allocations along funding opportunities to leverage efficiency, to evite duplication, and to increase impact. We need to use a clear set of indicators, because we're speaking about community engagement, but we need to show figures. We need to show clear impact proportionate to their resources, to the resources which are allocated. And never forget about that every activity we are doing, we need to align with the country standards. Because if we are speaking about the sustainability, we aim for sustainability, we need to see what the realities, because otherwise we're wasting resources and we're not leveraging what we can do. The results would be definitely partnership. I always say we need to speak more, we need to coordinate more, we need to understand that we are complementing each other and in this way to leverage the efficiency. And of course, why community engagement is important? It is important because we need to ensure that all the interventions serve the needs of and priorities of people affected by TB. And that's all from my side. Thank you.
Thank you very much for this strong message, Oksana. And there are plenty of questions and answers in the section. And please go, I'm encouraging all the participants go, and you will see open, answered, and dismissed questions. And in answered question, there are plenty of additional information you could find from our panelists and speakers. And I'm encouraging you to go there to get more information. And all of us us now. We are moving to marvelous Kenya, and Stephen Anguva, National Coordinator of Network of TB Champions, will present the experience. Steve? Now the presentation mode should be switched on, and then it will work.
Well, thank you very much. Good morning, good afternoon, good evening.
Yes,
Hope
please.
you are all well. Greetings all the way from Mother of Africa. This is all the way from Kenya. My name is Shikoli Stephen Anguva. I coordinate Network of TB Champions in Kenya. And it is a privilege and an honor to present on behalf of Kenya. And I really want to appreciate all TB champions in Kenya joining and those that are coming from the East African region. So I'll start my presentation. My focus today is reducing equity, human rights and gender-related barriers to improve access to TB services. Just building from my colleague Oxana on what we've seen in GC7 and what we propose to proceed moving forward into GC8. So one, we need to start by understanding what are these invisible barriers that we are trying to address when it comes to removing human rights barriers. Number one, the cost. Every time we talk about TB in the community, we tell people TB treatment is free, but there are those invisible barriers such as poverty and financial distress. Even when TB care is free, patients still face the following cost. Number one, transport to health facility. Number two, opportunities to loss of income. Another thing is dietary income. If you don't have food, you cannot heal. Definitely, there is a science that says that treatment to work, you have to have something in your stomach. So this is very critical and it's part of the cost implication when it comes to TB. The other thing is about the child care cost. And this cost mostly drive patient into poverty and cause treatment gaps. So you get that somebody has medication, but they cannot take it because of the additional cost, as well as those that go to delay treatment because they are unable to access this important support when it comes to treatment. The other thing is about social isolation. Sometimes when people get TB, they lose employment. They are rejected by family members. These are some of the stigmas that we see every day, which makes people not to come to facility for services. Another critical one is empty bottles. As you can see my photo there, sometimes when you go to facilities and you get that medicine is not there, and you have to come again for another refill. So back and forth to the facilities, which attributes to the aspect of poor supply chain management in some countries. And I think there was a time that Kenya was also experiencing such condition. Also, the lack of medicine can also lead to discontinuation of treatment, and people can develop even the complicated TB, such as drug-resistant TB. So what are some of these challenges broken down? I'll highlight two critical challenges when it comes to equity and access. Number one is social, cultural, and gender barriers. And how does these challenges manifest? Number one is masculinity norm. Traditionally, men are supposed to be strong, so strong man archetype, which discourages men from seeking care, leading to late diagnosis and higher mortality. You get that when a man visits the hospital, it is when TB has hit him so hard, so it discourages them. Domestic vulnerability. Sometimes in our space, in our setting, a man is the breadwinner. So when the woman is sick and gets TB, for them to access even health facilities, they have to borrow permission from the husband or from the fiance. They have to borrow money. These are some of the challenges that come in. Also, we have put our women to do domestic chores, so they don't have time to come to facilities because they have to take care of children and ensure that they are taking care of their husband at home. The other key critical point is stigma and discrimination. The high level of community and self-stigma has led to patients to conceal their status, delaying treatment and fueling transmission. There is some component whereby somebody is very fearful. If they talk about their TB status, they'll be excluded from social gathering, they'll be excluded from school, they will not even get employment. So somebody does not say they have TB. Sometimes they just say, I have an emergency. They are not even able to disclose that the emergency is TB because they know that still in this recent age, there is still stigma that moves along with TB. Then systematic gaps, traditional blanket service, whereby we say all services are coming from 8 to 5 p.m. So what about the population that don't have time, that time are not available to come for services? Definitely they will miss out. Those that are in prison, they'll be missed out. And those that work in remote areas, they'll be missed out because they can't operate like 8 to 5. Maybe flexibility is very critical. Challenge number 2, which is a financial barrier. As I highlighted earlier, catastrophic cost. Even when medicine is free, patients include massive direct non-medical costs, which include transport, food, indirect costs, which are very critical and very important when somebody is on TB treatment, they have to come for medication. A component of treatment abandonment, these are very critical one. The economic burden often forces Kenyans to choose between buying food or finishing their medication. So if you have been given an option, 2 options, you have medication, you have to buy medication, or you have to buy food. What will you do? And you have maybe 6 kids or 5 kids that they are waiting for you. You will prioritize buying them food. You will not prioritize buying medication or even going to the hospital. Then the burden of DRTB is still there in the country, and we are still struggling with it. So how have we responded to this challenge using GC7? One, the integration of national health insurance. Our TB clients or patients under the GC7, all our DRTB clients have been supported, integrated to social health insurance, whereby they get support for social support as well as medical support. So all the DRTB clients, and you see it is not for all clients, it's only for those that are having drug resistant. Also, this move, we see it at it shifts the burden from the donor funded project to sustainable national social safety net. What is the benefit there? This ensures that the DRTB clients have comprehensive cover, reducing the out-of-pocket medical expenses that previously hindered and led to treatment failure. So again, responding to the challenge about cash transfer, the targeted cash transfer is providing direct financial support to the most vulnerable TB patients to offset catastrophic cost. But still it's not enough because it is focusing on those that are DRTB, which is a portion. We have more than 122,000 Kenyans that are having DSTB that we think should also benefit in such initiative. Another thing is equity focus. Unlike general welfare, these transfers are TB specific, as I highlighted. And as I said, they reduce the aspect of treatment adherence, so they improve adherence. So how do we do in ensuring that we are reaching everybody and leaving no one behind? Number 1, we need accountability, very critical. Community-led monitoring. We need to institutionalize the iMonitor tool to allow patients to report service gap and discrimination in real time, which will help us in improved service delivery and health system. Number 2, we need to decentralize diagnostic. Let us reach people to where they are. When you wake up at your doorstep, if you're able to access the digital chest X-ray, then you are able to be screened and diagnosed for TB. Let us not wait for people when they are sick. Let us ensure that we are bringing services to where people are. We need to adapt and invest in new molecules that have always launched. For example, the AI-assisted screening tool. We need to have them accessed at every area, including in workplace, which will help reduce the treatment diagnostic time and will ensure that people are diagnosed on time and put on treatment on time. Remember, support the right to health for every person and everywhere. So what are our key and important interventions that we think are very critical? In GC7, we've seen a move away from treating the patient as a clinical issue, but now we are moving into making TB as a social issue so that everybody takes a responsibility and they're able to treat it. And the evidence there is that this was rooted from the community rights and gender assessment that was implemented, which highlighted the deep-seated barriers preventing Kenyans from accessing care. So now we don't need to wait for people to get sick. We are addressing them at their doorstep, and the goal there is to achieve universal health coverage by making health system accountable, accessible, equitable to the most vulnerable. As I wind up, what are our key asks for GC8 when we are moving in when it comes to human rights and gender? Number one, we need to scale up. We need to scale up programs to remove barriers, and the action there are very critical. We need to institutionalize legal literacy, stigma reduction, and access to justice. Because if people are not able to access justice, then justice delayed, sometimes it's justice denied. We need to move from small pilots to national-wide evidence-based intervention when it comes to removing barriers. Number two, we need to invest in gender transformative programming. We are really appreciating the GC8 human right concept note, but it needs to bring in the aspect of integrating gender transformative intervention and addressing social economic drivers to TB. And the key goal there is to address the root cause of vulnerability rather than just symptoms. We don't need to address symptoms, we need to address the root cause. Let us invest in those situations whereby legal aid clinics are done at the grassroots level. Number three, right-based integrated service. We need to safeguard patient confidentiality and community-led monitoring within the primary healthcare network. I know the GC8 information note talks about integration as the main thing, but let us remember, even when we're integrating in the primary healthcare, we need to maintain some of the interventions that were there and ensure that we do not lead to dilution. We don't need to dilute specialized services that our people with TB have been getting. So let us integrate, but integrate in an human manner, in a people-centered manner. Don't just integrate because the word integration, you've seen it. Let us ensure that even when we are moving into the aspect of integration, we are looking at people first before we look at systems. Then number four, which is very critical, let us strengthen community system and civic space. This is a space that let us engage communities at all levels. Secure direct funding for community-led advocacy and digital monitoring, such as iMonitor, as well as One Impact. If we have tools, let us invest in them. Let us put resources into these community-led advocacy digital tools, adapt them, and ensure that they are giving us information that help us improve systems. And the goal there is that the communities are the experts. The community have data. Let us use community-generated data to drive into national policy and accountability. If we address these four critical things in GC8, then I'm sure we'll be moving in the right direction when it comes to addressing human rights and gender-related barriers when it comes to TB. And having said so, thank you very much and looking forward to your valuable questions and additional inputs.
Thank you very much for presenting priorities for Kenya from Network of Tuberculosis Champions Kenya, and it sounds very ambitious in the current context. If there are any questions to Steve, please write them in the question and answer section. And actually, I'm now very happy that we have Atul Shenge from the Global Coalition for TB Advocates. And I guess, Atul, that you will be able to say from the community and civil society perspective, from advocates' perspective, what are the non-negotiables for the grant cycle 8, and what are the opportunities and possible impact on communities, how you assess it from this grant cycle 8. Please, Atul, the floor is yours.
Hi, I just wanted to check if my PPT will be up or should I be sharing my PPT? I have a short presentation.
You could share it, Atul.
I could share it? Okay. So, hello everyone. Good
Could you
afternoon.
please
good
make a slide mode?
Yes.
If it's possible.
Yeah. Yeah.
Yes, now it's brilliant. Yes, please.
Thank you. So, good afternoon, everyone, and good evening, good morning, and thank you for this opportunity to contribute to this discussion. My name is Atul Shendge, and I am a program officer with Global Coalition of TB Advocates. And in the first few seconds, I'll share reflections from the community perspective on GC8 TB guidance, focusing on key shifts, what must be prioritized, and this means for communities on the ground. So I'll start with who we are. I mean, don't get scared with too much words. I'll just touch upon it briefly. So GCTA is a global platform that brings together civil society organization and key stakeholders in TB response. Our work focuses on advocacy, strengthening community capacity, and ensuring that TB affected communities, especially those most marginalized, have meaningful representation in decision making. And for us, communities are not just recipients of services; they are partners in shaping priorities, implementation, and accountability. And this becomes even more important in GC8, where decisions around prioritization will directly affect who gets access to service and who does not. So what are the key shifts in GC8? We all have been talking about it, and we have been, we've all probably discussed also it. I'll just touch upon it again. Like, one of the defining features of this funding cycle is constrained financial environment, and the allocation that we have now is around 10.78 billion, which is lowest since 2020. And it's also below what we had originally expected and the target was. And at the same time, GC8 introduces a more structured approach through what we called program essentials, that is core interventions that countries are expected to include in funding requests or justify their exclusion. These emphasize system resilience, integration across TB, HIV, and primary healthcare, and measurable implementation. So overall, we are actually seeing a shift towards more, standardized, efficient-driven program and combined with reduced flexibility. And from the community perspective, the real question is whether these priorities will actually reach the people who still, who are still left out. And taken together, these shifts mean that TB programs will need to do more with fewer resources while also adapting to more standardized and integrated approach. So as for us, what are the community priorities? So given these shifts from the community perspective, what must be prioritized is not just the availability of tools, but equitable access to them. GC8, correctly emphasizes scaling up rapid molecular diagnostics, including near point of care, as well as point of care testing and aiming for universal access. But even today, about half of people are diagnosed using these recommended tests, and millions are still being missed. Many of those being missed are not invisible because the system cannot find them, but because stigma, fear, and discrimination keeps them away from these services. So there is also a strong evidence, on shorter and more, guidance on shorter and more effective treatment regimens, including all oral regimens for drug-resistant TB and shorter regimens for children, and an important push towards TB preventive therapy, especially for high-risk groups like people living with HIV and household contacts. These are all critical steps forward. But the key question here from the community lens is, are these actually reaching the people where they are, or are we actually, still expecting these people, our communities to navigate systems that are not, very friendly towards them or not designed by keeping them in mind? Because without the community systems, awareness and trust, even the best technologies and policies will not be translated into real impact. And often, it is like these medical aspects like trust, dignity, community support that determines whether someone seeks care, if they, even think of, or and also for the TB response, this means that improving tools alone will not be enough. we need to ensure that these tools actually reach the people who need them the most. So what are the non-negotiables from GC8's perspective? First, community engagement must be meaningful and not just consultative, but embedded in decision making and monitoring. Along with that, it is equally important to build the capacities of the communities, especially in TB, so that they can take on the responsibility of leading the TB response. Because till now, it's often like these policies, these programs, these guidelines are mostly written somewhere else, and communities are expected to implement this. So yeah. So for this to change, communities need to be well capacitated to identify gaps, engage critically, and hold systems accountable. And importantly, to push for what truly benefits community, not just what aligns with the donor's priority or technical agendas. And the response has to be shaped by the people most affected by TB. Next is what we are expecting. What is another non-negotiable for us is community-led monitoring must be protected, especially as countries are now expected to report against the defined indicators and program priorities. The other thing that we think is a non-negotiable is investments in human rights and gender must continue. There are often these are the often other aspects of non-medical criterias, but we cannot ensure adherence. We cannot ensure access if these what do you say the human rights aspect is not very well addressed, and these still remain a barrier for people to access care and support and treatment. Yeah, and finally, the whole conversation is actually what we're trying to say is that access must remain central. For example, diagnostics must be available for people where people are. And be it while we're talking about this, we're also including people living with HIV, because point of care. There are certain places where POCs are there, but they are not very efficient, or there are still some lacking, and which mostly what we've seen as people living with HIV do get sidelined because they are the lamp tests and everything are sometimes are not available. So we have to keep all of these, of all our populations in mind while we're talking about POC as well. And without without yeah without these, the communities will continue to face barriers even when services technically exist. So the risks and the realities of what we are anticipating or what we think is that while there are risks at GC8 also presents important opportunities for TB response. For example, the stronger focus on integration and system strengthening could improve continuity of care if implemented in the way that remains responsive to community needs. At the same time, we need to be realistic about the challenges in this funding cycle. We know that millions of people with TB are still not diagnosed or treated each year. And for drug resistant TB, less than half of those who need the treatment actually receive it. So, in these constrained environment, the gaps could widen, and there is a real risk that the community interventions, programs, and human rights work may be deprioritized because they are not seen as the immediate ones or something that medically needs more attention. So, but from our experience, these are exactly the interventions that determine whether uh, people are having access in the first place. In the communities we work, we still see people delaying testing or dropping out of treatment, not because the services don't exist, but because they're not accessible or not designed for them. And main reason for that is stigma and discrimination, where because of which people avoid going for testing. So the issue is not what we prioritize, but who ultimately benefits is what we think. Because we might prioritize a lot of things, but the perspective when we have while we're prioritizing it also plays a larger role in the whole TB movement and TB response. sorry. Okay, yeah. So I'll just conclude with that slide is probably missing here. Yeah. Hmm. GC8 provides a strong technical roadmap through improved diagnostics, better treatment options, and stronger integration. But achieving impact will depend on how they are implemented in real world settings. And communities are critical to bridging the gap, ensuring that services are accessible, acceptable, and equitable. Prioritization in a constrained funding environment is necessary, but must not come at the cost of equity or community-led response. Because ending TB is not just about medicine and diagnostic, it's also about addressing stigma, building trust, and ensuring people feel safe to seek care. We must protect and invest in these approaches, ensure meaningful participation, and remain accountable to those most affected. Because ultimately, ending TB is not just about delivering interventions, but it is about reaching people, especially those who are still left behind. So, with that, I would like to end my presentation. Thank you so much.
Thank you very much, Atul. And there is a good question from Caroline in the chat. It would be good to move it to the question and answer section, or to answer in written about any recent research findings to refer the how stigma is affecting an uptake of TB services. That's require the search and some links. So I'm encouraging panelists and experts here to help with the links and some materials to justify how important is to protect communities and affected people from stigma. Thank you, Atul. And we are coming now to the keyword nowadays is investment, and I'm giving a floor to Kaume Smith, program manager for the Community Rights and Gender Support Group in Stop TB Partnership. And I hope that Kaume could share with us some information about TB investment packages. Kaume, could you?
Sure. Can you hear me, Ghana?
Yes,
can you
I could
see my
hear you,
screen?
and I just if you'll do slideshow, then it will be easier for us to follow the slides. And beautiful
Sure.
picture you have on the slides.
Sorry, it's taking a bit of time here.
It's okay.
Is that it? Fantastic. Thank you all. Thank you all very much for inviting Stop TB Partnership to be part of this webinar today. My name is Kiva, and I am the coordinator of the Challenge Facility for Civil Society. Many of you will know it's a global grant mechanism for communities and civil society to advance their engagement and influence on the TB response. So just looking at this particular slide, this is information that is coming from the World Health Organization Global TB Report 2025. And so what we can see here is that the world is significantly off track on every major TB target, with the largest gaps in prevention, equity, and financing. So, for example, TB incidence has only fallen 12% since 2015 versus a 50% target. TB deaths are now down 29% versus a 75% target, and care and prevention funding is 73% below target. So despite this, and despite TB remaining the leading infectious disease killer globally, it continues to receive the smallest share of global fund financing. What is also true is that TB-affected communities remain underrepresented in many of the country coordination mechanisms, limiting their influence on funding decisions. And this will become apparent in a report that we are going to be releasing by the end of this month, entitled Strengthening Global Fund Country Coordinating Mechanisms and National TB Responses for Grant Cycle Grand Cycle 8 rather, Trends and Insights from 30 Countries, a report that was done in collaboration with CCM representatives, 10 community and civil society organizations, and again, having perspectives from 30 countries. So at the same time, we know that there are growing financial constraints, competing health priorities, and increasing reliance and push for integrated grant structures, risking, again, and diluting TB investments, especially those that are community-driven and essential to reaching underserved populations. But what is also true, as we all know, is that without community leadership, countries will not reach the missing millions, scale new tools, or ensure equitable access to services, hence this webinar. Therefore, Grand Cycle 8 has to be a strategic opportunity for the TB communities to really prioritize high impact, cost-effective interventions, strengthen integration with primary healthcare and pandemic preparedness, and to scale community-led, digitally enabled and data-driven approaches. And so the Stop TB partnership, together with our challenge facility partners and building on other support packages that we have done for other cycles, we developed a support package for, or we are developing rather, a grant support package for GC8, which aims to support the engagement, the effective engagement of communities in country dialogue and request development processes, to support our advocacy for the prioritization of essential life-saving interventions, and to ensure community-led, people-centered approaches, and that they are embedded and financed through GC8. So these are our group of challenge facility partners for challenge facility 2025 and 2026, being supported by Unit Aid and L'Initiative Expertise France. And the organizations that we are supporting are active in 15 countries, 2 regions, and there are 25 partners in total. And through the challenge facility, we'll be able to monitor and evaluate the engagement of communities in the country dialogue and development and proposal development processes, and to see how community-led and people-centered approaches are eventually embedded and financed. So we look forward to working with partners on that. But for today's purpose, what I will touch upon one area of our support package, which is really the articulation of TB priorities in GC8, which incidentally align with the 4 pillars of the Challenge Facility for Civil Society, namely, number 1, life-saving community TB prevention, early diagnosis, treatment, care, and support. Number 2, removing barriers, reducing stigma, and ensuring access for all. Number 3, generating demand and financing for new tools and innovations. And number 4, strengthening community systems and sustainability of integrated TB services, which I think aligns with previous speakers, both from the Global Fund and community partners. And so for us, we don't see these as separate categories at all, but they rather represent a continuum of innovation, impacts, and sustainability, again, aligning with the principles and the strategic shifts within GC8. So number 1, in terms of TB priorities, is life-saving community TB prevention, early diagnosis, treatment, care, and support. Because as we know, prevention, early diagnosis, and effective treatment deliver the highest return on investment. They save lives and reduce transmission and lower long-term system costs. So the interventions that we are promoting, let's say, and prioritizing are community and facility-based TB screening, targeting underserved populations. Again, interventions that we've spoken about at length today already. Contact tracing and active case finding using rapid molecular diagnostics and next-generation tools. TB preventive therapy for household contacts, people living with HIV and other risk populations. Integration of TB screening into primary healthcare and community platforms, strengthened referral systems, decentralized community support treatment for all forms of TB, including DRTB and shorter regimens, and treatment adherence and people-centered support, namely peer support, treatment literacy, psychosocial and mental health services, and digital adherence tools. Because as we know, effective community leadership is really critical because it improves early case detection, adherence, and so on and so forth, which has been demonstrated through Global Fund work, as well as TB Reach and Challenge Facility partners. Number two, which we have spoken about and heard in particular from our community partners, is really on removing barriers, reducing stigma and ensuring access for all people. Because as we know, stigma and other system barriers are among the primary drivers of delayed diagnostics or diagnosis, poor adherence and ongoing transmission. So the priority interventions that we are recommending are community-led monitoring of TB care barriers, as we've heard from our partners before, notably One Impact, as the largest CLM platform in TB, if not in other areas. Today, as many of you know, we have over 500,000 people engaging on this platform, and it's being used also in 38 high-burden TB countries. Stigma reduction and interventions to overcome systemic barriers, and just noting the question that came before, we have both a One Impact global report as well as a TB stigma portal. Which combines all of the data that was done across a number of countries using the TB stigma assessment, which highlights that in fact TB stigma is one of, if not the major barrier to accessing TB care services. So I will share those resources with you for your referral and use. Number three is around stigma-free TB services models with health worker training, targeted outreach to underserved populations, and integrated society and economic support where needed. Because again, effective community engagement is critical because it generates real-time, people-centered data on service gaps, strengthens accountability and service quality, and builds that trust with health systems that we need. And we have a lot of this evidenced if you can visit here, the One Impact Knowledge Hub, which really demonstrates with several case studies, looking at how community-led monitoring is really addressing these systemic barriers to care. Number three is about generating demand and financing for new tools and innovations. And priority interventions here that we are recommending is community-led demand creation or generation for rapid diagnostics, short treatment regimens, digital health tools, TB vaccine readiness, community engagement in policy dialogue and priority setting, protection of social contracting mechanisms, advocacy for domestic resource mobilization and sustainable financing, policy and legal reform to institutionalize community roles. Again, we're really just echoing what both Global Fund and what our community partners have already said. And we have some great examples stemming from this current round of the Challenge Facility under the Unit Aid Respect project, which really speaks to the importance of communities generating demand for essential services. And then number four is strengthening community systems and sustainability of integrated TB services, because without strong community systems, gains in TB responses really cannot be sustained or scaled. And the priority interventions that we are recommending are capacity building of TB affected communities and civil society organizations, support for community-based service delivery and advocacy structures, and investment in community digital platforms for people support, data collection and real-time support, service navigation, and AI-assisted guidance tools, and the institutionalization, most notably of community roles through social contracting and policy reform. Again, because effective community engagement is critical, as we know, in all of these areas. So in terms of next steps for the Stop TB partnership, we will release this CCM report, which we hope all of our community partners will be able to use and leverage to ensure a better representation and thus influence of affected communities, TB communities on CCMs. This report also provides recommendations to the Global Fund Secretariat, as well as the board, as well as national TB programs and community and civil society organizations. So we do very much hope that this can be a very practical, useful report for your advocacy. We will be finalizing this Stop TB partnership support package for TB communities and civil society the week of the 4th of May. And then together with TB People, the global network of people affected, a global network along with GC8 of people affected by TB. And we'll be working with Georgetown University as well on a series of webinars on maximizing Global Fund proposal. There is a series of webinars, as you can see here. There's 7 of them, and they will commence the week of the 27th of April. And we will touch upon issues regarding Global Fund, GC8 timelines and CCM governance, new tools, GC8 TB community content and priorities, where this support package will be developed and presented in full, aligning with the Global Fund modules and interventions as was presented by our colleague from the Global Fund today. We'll be looking at issues around procurement, MDR-TB, transition, and integration as is being pushed for and being advocated for. So we hope that you, as many of you as possible, will be able to join this webinar series starting the week of the 27th of April. So I will stop here and thank you all.
Thank you very much, Kiva, for overview and for more possibilities to learn, because there are plenty of issues we could not touch during this short period of time. But what I want you to stay more for at least 5-7 minutes to hear about the tools and resources available in the Global Fund for community engagement in Cycle 8. And I'm giving floor to our friend and colleague Niluka Dilshan Perera, Senior Program Officer from Community Engagement Strategic Initiative in Community Rights Gender Department from Global Fund. And Niluka, please, I know that the time is very short, but we need to hear the tools and the possibilities for technical support which community could use right now. Please, Niluka. I see the presentation, but I couldn't hear you.
That's because I was on mute. Thank you for pointing that out. There are several channels of support available for communities to engage in GC8 country dialogue process, and every presenter emphasized, and we can't emphasize enough how important it is for communities to engage in the country dialogue process during consultations, during funding request development, all the way into grant making and grant implementation, given that for a number of countries, these are the final grants or the last grant before a transition grant. As you know, there are several tools available that are supported by the Community Engagement Strategic Initiative, and there are tools available from other technical partners as well. Let me start with the first two channels of support available, the short-term technical assistance and rapid engagement support. The short-term technical assistance is provided to community-led organizations to deliver well-coordinated TA to support community engagement in country dialogue process, including in funding request development and in grant making. This provides a maximum of 20 to 30 days of consultancy to support communities to do desk reviews, rapid reviews of programs, bring communities together for consultations, develop community priorities, validate them, and then to engage in grant making processes. We are not currently accepting applications for countries submitting in window 1 and 2, but we have the opportunity to look at potential applications for countries submitting in window 3 and in later submission windows. Please reach out to your respective Global Fund regional learning hubs in your region to get more information. They will be supporting you with the application process as well. And right after I finish my intervention, I will post the link to all the contact details of all the learning hubs. And the second channel of support from the Community Engagement Strategic Initiative is rapid engagement support. This is a small amount of resources, a maximum of up to 5,000 to look at to support communities to engage to deliver consultations as part of the broader CCM roadmap on country dialogue and funding request development. Just a caveat, the resources are limited, so I'm not saying that we will be able to provide these small rapid engagement support grants to everyone. So please please reach out to your regional learning hubs and explore with them how best to access rapid engagement support in your region. These are the learning hubs for all the 6 regions. I will put the link and you can just access them through the link, but they will be supporting you with the TA applications as well as exploring the possibilities for rapid engagement support. Here, I'm showing you the community engagement toolbox. This is under community engagement strategic initiative. This, as you can see on the screen, different tools are categorized under different themes. We are updating this toolbox by the end of this month, and this will include all the updated tools which will support you in terms of conducting consultations for country dialogue process, costing community priorities, engaging in grant making, advocacy, accessing technical assistance, all of that. At the moment, our regional learning hubs and also other community engagement strategic initiative partners are developing really important tools to support community engagement in GC8 processes. Here are 6 main tools that we are currently working on, including GC8 community consultations, which will give you a really good overview of organizing community consultations and what must I know about GC8. This is already published. Sustainability and transition, a tool that will provide you insights into how do we understand and bring the ideas of sustainability and transition into GC8 country dialogue conversations. Service integration, a key topic. This tool is looking at how, as communities, we need to understand integration. How do we bring this topic into different discussions and dialogues we are having as part of GC8 country dialogue process. Community costing tool, a lot of community partners have used this in GC7, and this is a tool that will help communities to cost community priorities, which is a key piece of really pushing community priorities into funding requests. And the last one is on community guide on RSSH. And we are currently working on these tools, and they will be also included in the updated toolbox by the end of April. That's the end of my presentation. Once again, to say that all of this support is available through your regional hub, your respective regional hub in the region. So please feel free to reach out to the coordinators and hosting organizations and explore with them what kind of support is available to you to engage in GC8. And I am also including the link to the contacts in the chat.
Thank you very much, Niluka. And I need to say that our panelists not only prepared presentation, not only did amazing job in their field of work, but also answered a lot of questions. And I guess that in the report from the meeting, we will take questions and answers to the report for you to summarize. But if you need to learn something, please go to the session on answered questions and learn more details about the community engagement, community participation in the proposal and in the TB response under the Grant Cycle 8 funding. So on this mode, I need to say that yes, we will have all presentations shared to all attendees and registered attendees. We will share the video of this webinar in the languages we had. And I'm very grateful to all participants and all panelists for this rich discussion. And I sincerely wish you all the best in this very heavy process of negotiations. And I wish you to have a good feeling about the word integration and transition and actually to achieve our joint goal to have healthier people and more protected and more equal access to the important life-saving services. Thank you very, very much all for this time together and happy day today. Let us breathe freely and enjoy what we're doing. Thank you very, very much.
Thank you.
Oksana, you wanted to say just to say hello, thank you and goodbye, and see you next time for the workshops and webinars of the learning hubs of Global Fund.
Thank you so much.
Thank you, colleagues, and bye.
Bye. Thank you. Bye.